Hello everyone, welcome to your lecture on the cardiovascular system. Please go ahead and use your guided notes that you got in class to take notes as you're reviewing this lecture. These are the learning objectives that we will be covering. What is perfusion? Perfusion is basically the process by which the body gets oxygenated through the capillary blood that passes through the different tissues of the body. The lung tissue perfusion depends on positioning and activity, whether the person is sitting, standing, lying down. Perfusion is greater in dependent areas. A person's activity level, for example, greater activity results in an increased need for cellular oxygen by the body's tissues, including the heart muscle, and a subsequent increase in cardiac output. An adequately functioning cardiovascular system is important and vital for exchanges of gas. The perfusion of body tissues, including your organs, for example, your kidney, your liver, all of those, depends on adequate blood supply and a cardiovascular system. The problem with ventilation and perfusion, as we discussed in your lecture last week on the respiratory system, is hypoxia. That's what can go wrong, right? Your body tissues not getting perfused. So let's look at a brief overview, anatomy and physiology of the cardiovascular system. The cardiovascular system's main function are cardiac output, delivering oxygenated blood to the tissues, and returning deoxygenated blood to the heart. How is this done? By that muscular pump, which is called the heart, and a large complex system of arteries and veins. The major difference between arteries and veins are that arteries carry blood away from the heart, and veins carry blood to the heart. A lot of times people say arteries always carry oxygenated blood and veins always, carry deoxygenated blood. But that's not the case all the time. And we're going to talk about this when we talk about blood flow. But right now, let's talk about some differences between the arteries, veins, and the capillaries. Arteries are high pressure. Remember, the blood pumps the blood into the, circulatory system. And over there, the pressure is high. And so the walls of the vessels of arteries are thicker to withstand that pressure. They always carry blood away from the heart. The largest artery in the body is your aorta, that's on your heart. A series of vessels then gradually decrease in size, enter into smaller vessels, into capillaries, and then to regulate this volume and pressure in the arterial system and rate of flow to the capillaries. For example, basically what that means is that when the blood is being pumped from the heart, it's very high pressure. When it gets to the arteries and arterioles, the pressure decreases because they're very tiny, very, very tiny. And at this capillary level, that's where blood is, provided to the tissues. Now, the venous system is a low pressure system because remember, this is the return pump. This is the blood coming back to your heart. And so it's a low pressure system. It carries blood to the heart. Remember, arteries away from the heart, veins to the heart, right? These vessels, all your vessels in the venous system have valves. This helps to prevent backflow. For example, when the blood is being, transported back to the heart from your, say, lower extremities, there are valves in your veins which help push the blood up and close. That way the blood doesn't have backward flow. The largest vein in your body is the vena cava, the superior and inferior vena cava. 75% of the blood volume in your body is contained in the veins. So the contraction of the muscles in the extremities also helps return the venous flow back to the heart, right? The walls are flexible to adapt to changes in pressure. And the way it flows is it goes from the capillary bed to the venules to the veins, and then from the veins to the right heart. So remember, veins carry blood to the heart. They have valves which prevent backflow, and the muscular contractions help push the blood back towards the heart. Then we have the capillaries. They're single-layered endothelial cells. They're interwoven between tissues. Capillary beds, the diameter is about 5 to 10 centimeters. And oxygen, nutrients are delivered to the tissues at the capillary level. Cellular waste is removed. They're abundant, and in the body, there are billions of capillaries. Muscle cells and, precapillary sphincters at the entrance of the capillaries constrict and dilate to deliver and constrict blood flow. So the way the flow goes is that from the capillaries, it goes to the venules, and then the venules to the veins. So remember that flow, right? It goes from the arterial system, it goes arteries to arterioles to meta-arterioles to the capillaries. Then once the tissue is oxygenated, and it provide the nutrient exchange happens, the blood, the perfusion happens, and then from the capillary beds it goes to the capillaries, to the venules, and then the veins, and then back to the heart. These are some diagrams on the arterial and venous flow. If you notice here, that's your heart, right? So the heart, the deoxygenated blood that's coming from your body, your kidneys, your liver, everything, and then it comes up here, goes into your heart, and then from your heart it goes to the lungs to get oxygenated, and then the oxygenated blood is then returned to the heart and then is circulated to the rest of your body. So always remember, arteries carry blood away from the heart. Veins carry blood to the heart. So this is a one-way street. It goes out, comes back in, goes out, comes back in. One way. It does not, it's not a two-way street. This is a really good diagram that shows the flow of the blood. Now let's talk a little bit about the anatomy of the heart. Where is it? It's a hollow fist-shaped. If you make a fist, that's the size of the heart, your heart. It's a hollow fist-shaped sized organ located in your thoracic cavity, right here. And it's between the lungs in the space called the mediastinum, right here. It lies behind the sternum. Your sternum is right here, so it lies behind the sternal area right here, and it rests on the diaphragm, which is right here, as you can see, the diaphragm. It weighs about 10.6 ounces, and the weight and size depend on age, gender, body weight, physical exercise, conditioning, and any existing heart diseases. So the layers of the heart, the outer layer right here is the epicardium. Right, that's your epicardium right here. And then you have your middle layer right here. That is your myocardium, the muscle layer, responsible for the pumping action. So this is the one that's responsible for pumping. Then you have the inner layer right here, this really thin one. This is the endocardium. This lines the interior of the heart, and the heart is also encased in a thin fibrous sac, the pericardium, which is right on the inside. So these are the different layers of your heart muscles and heart tissue muscle, So what makes the heart pump? What makes the heart pump is the rhythmic contraction and relaxation of the muscular walls and its chambers. It's the pumping action. For example, systole is the period of contraction. When the heart contracts, it pumps blood, ejects blood to your arteries, right? Then diastole is the period of ventricular relaxation, which helps in ventricular filling, because when your heart contracts, pumps the blood out, then the ventricles relax, which helps to fill the blood, the deoxygenated blood, back in to your ventricle, and the oxygenated blood back into your ventricles, so they can be pushed out either to the lungs or to the body. Chambers of the heart. So we talked about the primary function of the heart. We talked about the anatomy of the heart, the outside, the layers, of the heart. Now, the chambers of the heart. These are the inside. This is the inside part of the heart. You have your right atrium right here. Then your right ventricle. These receive your deoxygenated blood. And then we have your left atria and left ventricle. So these receive the oxygenated blood and pump it out to the body. So these are the four chambers: right atrium, right ventricle, left atrium, and left ventricle. Please watch the videos that I posted in your Canvas so you can, it will help you to understand the flow. Then we have valves in the heart, right? We have valves that open, they open and they close. So you have these little valves right here. You see the tricuspid valve, the semilunar valves, the AV valves. They're in different locations in the heart. Please watch the videos I posted in Canvas to better, understand how the blood flows from here. So what happens is when these valves open, the blood flows from the atria into the ventricle. Then the ventricle fills and the pressure increases. When the pressure increases, the valves close to prevent any retrograde flow. Now it needs to keep it in the ventricle till it's ready to pump, right? And then they open and close in response to changes in pressure. It's always a one-way flow, just like the rest of the body. It's a one-way flow. Semilunar valves are between the ventricles and the arteries. The pulmonary valve, that's between the right ventricle and the pulmonary artery. Then you have the aortic valve between the left ventricle and the aorta. The AV valves are between the atria and the ventricles, AV, atria ventricles, and they're on the right and the left side both. So the tricuspid valve is between the right atrium and right ventricle, and the bicuspid or mitral valve is between the left atrium and left ventricle. Once again, please use the link in Canvas that I placed so you can understand how they open and close and see how the blood flows. This is the link, right? This is the video that I posted in Canvas. This is another video. It's 2 minutes long. Excellent video that explains the blood flow of the heart. So let's talk a little bit more about the blood flow of the heart. How does blood flow through the heart? Right? The first thing is that deoxygenated blood, and remember, this is all happening simultaneously and very fast, right? Every beat of every heartbeat, this is happening over and over and over and over again, right? A normal person's, an average healthy person's heartbeat should be between 60 beats per minute to 100 beats per minute. So this is happening 60 to 100 times every minute. It shows how efficient and how effective the heart is, right? So the deoxygenated blood, it enters through the superior vena cava and the inferior vena cava right here. This is the deoxygenated blood that comes from your body, and it enters into the right atrium right here. From the right atrium, the blood, enters then into the right ventricle through the tricuspid valve. And then from the right ventricle, the blood is pumped out to the lungs, because remember, this is still deoxygenated blood, right? And so it's pumped out to the pulmonary artery, sorry. And what does the pulmonary artery do? The pulmonary artery is going to take it to your pulmonary system. Those are your lungs, right? Because that's where oxygenation happens. Now, remember we mentioned that the main difference between arteries and veins is that arteries carry blood away from the heart and veins carry blood to the heart. Arteries don't always have oxygenated blood. And veins, so if you look at right here, as the blood is being pumped to go to the lungs for oxygenation, this is an artery. And this artery actually has deoxygenated blood. If you notice, it's blue. That's the left pulmonary artery and the right pulmonary artery, right? So, and that shows that an artery can contain deoxygenated blood. So the only difference is arteries go away from the heart, veins go to the heart. So now once this deoxygenated blood goes out of the pulmonary artery, it goes to your lungs, it gets oxygenated, and then it will return with oxygenated blood from your heart. So oxygenated blood returns to the heart from the pulmonary veins. If you notice right here, you have the right and left pulmonary veins right here, and this is the left one right here. Now, this is a vein, right? It's a pulmonary vein. It's going to the heart, but it has oxygenated blood. So it goes to show that not always do Do arteries carry oxygenated blood and veins carry, deoxygenated blood. So from these veins, the oxygenated blood returns to the heart. And where does it go this time? It's going to go to the left atrium. Because remember, deoxygenated blood was going to the right atrium and right ventricle and getting pumped out to the lungs, comes back from your pulmonary veins into the right atrium. Once it gets to the right atrium, this is where your oxygenated blood lives, it's going to go, if you notice here, your left atrium, is going to go into your left ventricle. And from your left ventricle, it's going to get pumped out into your heart via the aorta, the biggest artery of your body. And these are the biggest veins of your body. The superior and inferior vena cava, and aorta is your biggest artery. Now, as it gets pumped out of the artery, the aorta, you're going to notice there are these little tiny arteries that branch off the aorta, which take the blood to different parts of your body. So this is the way blood flows through the heart. Please watch those videos and we'll talk about this a little bit more in class. Here's a mnemonic that you can use, to help you remember the blood flow to the heart. This is a video I posted in Canvas. Please, look at that. Now, the blood pumps, oxygenated blood to the rest of the body, right? But does the blood need oxygen, oxygenated blood? Of course, the blood needs blood supply as well. The heart needs blood supply as well. So the myocardial blood flow is blood vessels that provide oxygen and nourishment to and remove waste products from your heart muscle, because your heart muscle needs perfusion too. If you don't have perfusion in your heart muscle, your heart muscle will die, right? So the main blood vessels that provide coronary circulation are the right and left coronary arteries. These are the ones that supply oxygenated blood to your heart muscle. Then the blood returns to the right atrium after passing through the heart via the cardiac veins. And then with the normal heart rate of 60 to 100 or 80 to 100 beats per minute, there's ample time during the diastole for myocardial perfusion. Remember, we said during systole, the heart is contracting and sending blood to the rest of the body. It's during diastole, the resting period, right? That's when the perfusion of the heart happens. So if people, have problems with their, during diastolic heart failure, what that means is that during diastole, the heart, there's not enough time for the heart muscle to get perfused. And if it doesn't get perfused, then you can end up with ischemia of the heart tissue and cause myocardial ischemia and leading to a heart attack. Now let's talk a little bit about the physiology of the heart. We talked about the anatomy, the structure of it, where it lives, the layers of the heart, the chambers of the heart, how blood flows through the heart, and how the blood, heart muscle is perfused. Now let's talk about the physiology of the heart. Before we, dive more deep into it, let's talk about the cardiac conduction system first. What is this? This is the electrical conduction. Now we have your heart muscles, your chambers, your valves, everything, but what makes it contract is the electrical conduction. The cardiac conduction system, it generates and transmits electrical impulses which stimulate your cardiac, the cardiac muscle so it can contract. Right? And the depolarization is the time, that's the movement of the ions before the heart contracts, right? Repolarization is when the ions return back to the resting state to allow the heart to rest, right? And so it can initiate another contraction. Now remember, this is happening 60 to 100 times every minute. That's the normal heartbeat. Right? So imagine how fast this is happening, how hard the heart is working every minute to perfuse your body. This is the cardiac conduction pathway. So the impulses start right here. This starts at the SA node, the sinoatrial node. Then the SA node has an inherent rate of 60 to 100 beats per minute. Right? And now this impulse spreads down. It spreads through the atria, through the internodal pathways, and then they go to the atrioventricle node where the impulse is delayed to allow for atrial contraction, then and complete ventricle filling. So now it gets delayed until your ventricles fill. Once your ventricles fill, then the right and left bundle branches, which travel down to this area right here, the septum area, right? The Purkinje fibers, which extend the impulse in through the ventricles right here, and it facilitates ventricle contraction. So it will first start here, help the atria to contract to push, the blood into the ventricles. It rests while the ventricles are filling, and then it gets ready for the ventricles to contract. So people who have conduction problems, they usually get a pacemaker. So this is when they will get a pacemaker right here by the SA node, and, to help them with the contractions. Now, when the conduction is happening in the heart, it creates a rhythm, and that is called an electrocardiogram, an ECG, right? The electrical activity, it produces these waveforms, which can be amplified and viewed on a paper tracing. That's called your ECG. So the way we do this is we place electrodes on the wrists, ankles, and 6 locations. There are different types of EKGs, and the electrodes will pick up on the contraction. So this is the P wave right here, PR interval right here, the Q wave, then you have, the STU, and that is your entire contraction. This is the cardiac cycle right here. So once again, the circular sequence of events. This is your diastole. The ventricles are relaxed right here and waiting to get filled. And then once they're filled, then the ventricles push really hard to get the blood out into your circulatory system. If you notice over here too, down here, the right ventricle, the left ventricle, sorry, it has very strong, thicker muscles because it has to contract very hard to push all of that blood into your entire body. Remember, this fist-sized organ, your heart, is doing this every 60 to 100 times a minute. And the same fist-sized organ is perfusing your entire body 60 to 100 times per minute. So how is blood pressure, determined from this circulation, right? The pressure is generated through the cardiac cycle. The force against the vessel walls by the blood flow are influenced by cardiac output and vascular resistance. The 2 pressures that are reported are your systolic, which is the highest pressure generated. That's when your left ventricle contracts and then the blood gets pushed out. That's the highest pressure. That's your systolic, right? Your diastolic is the lowest pressure maintained in those arterial walls during relaxation. So the mean arterial pressure, the average arterial pressure throughout the cardiac cycle is calculated by adding the systolic twice, 2 times the systolic plus the diastolic divided by 3. Systolic plus 2 times the diastolic divided by 3. So let's talk a little bit more about blood pressure. How is blood pressure regulated? Blood pressure is regulated by your autonomic nervous system and brain stem centers. Remember, we talked about these little receptors that are everywhere in your body that sense temperature, sense fluid volume, sense all these things, right? Your pH values and the cerebrospinal fluid. The same way you have your, brain stem centers as well that sense blood pressure. Now, the autonomic nervous system, through its influence, it influences the cardiac rate, the cardiac contractility, and your vascular tone. The heart, through the branches at the thoracic level of the spinal cord. So it can, how does it, affect blood pressure? through the heart. That's through the branches at the thoracic level and spinal cord. You have sympathetic fibers that stimulate the heart to beat faster. Remember the sympathetic nervous system. Then you have the parasympathetic fibers. What do? They do the opposite. They innervate the heart through the vagus nerve and results in a slowed heart rate. Remember those sympathetic and parasympathetic nervous systems. Then you have the vascular system, the blood vessels that are innervated by the sympathetic fibers. Sympathetic maintains the blood vessels in a constant baseline state of partial contraction. Vascular tone, it maintains the blood pressure, blood flow, even when the person is resting at sleep. Because remember, your blood doesn't stop pumping and your body does not stop the circulation while you're sleeping. It's still happening, right? So then you have the sympathetic stimulation beyond the baseline tone varies in response to the body's needs. Increased sympathetic stimulation causes what? Constriction of some of the vessels, for example, your skin, your GI tract, and your kidneys and stuff. And then dilation of your other vessels, like your skeletal, muscle vessels. So this shunts blood flow to the skeletal muscle in a fight or flight response. For example, when, the blood flow is low, or blood pressure is low, your body is going to perfuse your essential organs, right? So it will constrict the vessels, where it's needed the most. Then we have the brainstem centers. These also regulate blood pressure. They integrate feedback from the baroreceptors and the chemoreceptors in the body to regulate cardiac function and blood pressure. The vasomotor center controls the sympathetic stimulation of the heart, vascular system. The cardioinhibitory center controls the parasympathetic slowing of the heart, right? So then you have baroreceptors. Where are these? These are located in the walls of your heart and blood vessels, and they're sensitive to pressure changes. So when the baroreceptors sense a drop in pressure, what happens? They send a message to the brain center that stimulates the sympathetic nervous system. And what's going to happen? The heart rate will increase. You'll get vasoconstriction, and this allows, then this makes the blood pressure go. It increases the pressure of the blood. And so this happens during position changes, right? And it helps us to maintain our blood pressure during position changes. Remember, we talked about orthostatic hypotension. So when people, sometimes with position changes, an average healthy person, blood pressure will work along with them and the pressure will be stable. But for people who have orthostatic hypotension, when they're changing positions, this doesn't happen for them. And so their blood pressure drops as they're changing positions. Chemoreceptors, similar to baroreceptors, but they're located in the aortic arch and the carotid arteries, and they're sensitive to changes in blood pH, oxygen levels, and carbon dioxide levels. Their main function is to regulate ventilation, right? But they also send information to the vasoconstrictor center in response to a lack of oxygen. Then the vasomotor center responds by, activating the sympathetic stimulation. Then what happens again? Then your blood pressure increases, more perfusion happens, and more oxygenation happens. Why does it matter? Why does all of this have to happen, right? Because adequate blood flow to the tissues and cells is extremely important, right? And an effective cardiac pump, adequate vasculature or circulatory system, and sufficient blood volume is important for life. If one of these components stops working, then tissues do not get perfused. And then what happens? We have inadequate blood flow, which results in poor delivery of oxygen and nutrients to all the cells in the body, and that causes hypoxia and cell death and can progress to organ dysfunction. So if your organs do not get perfused, do not receive blood supply and oxygenation and nutrients, they would die. Okay, let's talk about cardiac output. We mentioned it, but we didn't talk a lot about it. But let's talk about cardiac output. So hemodynamics. What is hemodynamics? This is the study of the forces involved in circulation of blood within the body. This involves the principles of fluid dynamics and how they apply to blood flow pressure. Hemodynamic monitoring helps us is we use these pressure monitoring devices to directly measure the cardiovascular function. What is cardiac output? Cardiac output is equal to heart rate times systemic vascular, your stroke volume, sorry. What is that? First you have your heart rate, right? The number of contractions per minute. A person has 60 to 100. This is, affected by your autonomic nervous system, as you mentioned, your sympathetic nervous system, your parasympathetic nervous system, epinephrine and norepinephrine release, during or adrenaline during, and flight and fight response. So all of these affect your heart rate, but the normal heart rate is 60 to 100 beats per minute. So your cardiac output is your heart rate times your stroke volume. What is your stroke volume? The stroke volume is the amount of blood that's getting pushed out into the system. So this depends on preload, the amount of blood in the ventricles. Remember at the end of diastole, when your ventricles are filled, and then the ventricles contract to push the blood out into your body, that affects your stroke volume, how much blood you're ejecting out. The afterload, this is the peripheral resistance. What is peripheral resistance? That's the resistance that we get in your arteries when the blood is being pumped out into your arteries, right? And this can, in the increased afterload, if you have too much afterload, that can result in decreased stroke volume, decreased ejection of the blood into the system. Systemic vascular resistance is the resistance of the systemic blood pressure to the left ventricular ejection. The pulmonary vascular resistance is the resistance of the pulmonary blood pressure to the right ventricle ejection. Because remember, the right ventricle pumps blood to your pulmonary arteries to your lungs to get oxygenated. Your systemic vascular resistance is when your left ventricle pumps blood into the circulatory system, into your aorta, which sends blood to the rest of your body, right? So this is calculated, and then the contractility of the heart, right? That also affects cardiac output. It's the squeeze force of the muscle contraction that also, affects your cardiac output. The cardiac output and adequate cardiac output is extremely important for your body to get perfused properly. So this is called the ejection fraction. This is the percentage of the end diastolic volume of the blood that is ejected with each heartbeat. The normal ventricular ejection fraction is 55% to 65%. This is used to measure myocardial contractility. Now, any ejection fraction less than 40% shows decreased left ventricular function and, probably will indicate heart failure. What are some abnormalities in our cardiovascular function? You have heart failure, right? You could have left-sided, right-sided heart failure, both-sided heart failure. And we're going to talk a little bit more about heart failure in our heart failure lecture. Then we have cardiomyopathy. That's a heart muscle disorder. You could have cardiac ischemia that can lead to a heart attack, MI, myocardial infarction, angina pectoris, and chest pain due to myocardial ischemia, death of the cells on your heart muscles. Coronary artery disease. This can lead to blood clots. Dysrhythmias. These are alterations in the heart rate or rhythm. This happens when your electrical conduction system isn't working properly. Then you can have abnormalities in your valves, right? So these are the different parts of your heart that you can have problems, right? You have your heart muscle, you have your valves, you have your, chambers, you have the electrical conduction of the heart. And then, so there are different areas that can go wrong in the heart, right? So the valves can become stenotic. That means they can become narrow, or valves can become incompetent, right? Then you have arterial abnormalities, you have venous abnormalities. You can have oxygen transport abnormalities. That's, for example, anemia or carbon monoxide poisoning, right? So all of these are abnormalities that can occur in the cardiovascular function. How can we promote circulation and prevent blood clots, right? First thing is to manage anxiety. Always speak calmly to your patient. Don't leave the patient alone when they're anxious. Be there with them to, help calm them down. Provide clear factual information to them. If you can reduce their anxiety, which then can, positively affect their circulation. Promote circulation by elevating the legs above the heart. Gravity promotes venous return, right? You want to tell the patients not to cross their legs because that interferes with their blood flow. Early ambulation. After surgery, you want to promote early ambulation. The sooner they get up and walk around, the better their blood will flow, right? Then you want to do frequent ambulation because we know how impaired mobility affects everything negatively, right? So we want them to frequently ambulate because this will promote contraction of their leg muscles, which actually, remember we said the venous return from your lower extremity and your body is helped by muscular contraction. And if they get up and walk around, then that will help with that contraction. Then you can also apply compression stockings. These can be anti-embolism stockings, TEDHOs we call them, or that you can use sequential compression devices. Those are the ones connected to the bed and we turn them on and they intermittently, squeeze and relax, squeeze and relax. This helps to promote that venous return back to the heart. Then how do we prevent clots? A thrombus is a stationary clot that's attached to the vessel of the heart, of the veins. An embolus is a clot that's detaches and it's traveling in the bloodstream. What can go wrong over here? That clot can end up in your pulmonary system and you can end up with a pulmonary embolism where, your oxygenation stops. All right. So how can we prevent clots? We can prevent clots through anticoagulant therapy. That's your heparin, your warfarin, apixaban. By turning patients frequently, this prevents the vessels and injury from pressure, right? Use scrupulous technique when you're providing IV therapy. Make sure you use sterile technique, make sure everything is clean because this can help prevent the infection in your, veins and damage. That can lead to damage, Promote adequate hydration, approximately 2 to 3 liters a day. Unless it's contraindicated for patients with heart failure, it's sometimes contraindicated. This can help prevent the blood from becoming viscous. That means viscous, that means thick, right? You want to keep that blood thin and flowing. And then we have promote smoking cessation. Why is that? Because nicotine increases the risk of blood clot formations, thrombus formations. And then it also, how does it do that? It does that by constricting the vessel walls. And so we want to encourage our patients to stop smoking. What factors influence the cardiovascular function? Developmental stage. Infants, adolescents, older adults, depends on their age. There are different factors that can influence their cardiovascular function. For example, in older adults, they might have, hypertension or high cholesterol, hyperlipidemia, or other, chronic issues that can affect their cardiovascular function. Infants can be born with, heart diseases that can, affect their cardiovascular function. Adolescents, their lifestyle, like if they're taking drugs, if they're taking alcohol, all those things that can affect their cardiovascular function. The environment we live in also affects our cardiovascular function. You have stress, you have allergic reactions, the air quality we're breathing in. If you're in high altitudes, heat and cold, all of these heat and cold environments can also, affect your cardiovascular function. Lifestyle is a huge one. During pregnancy, your metabolic demands are much higher, and that can affect your cardiovascular function. Nutrition, we should encourage patients to eat a low-fat, low-sodium diet. Make sure they're getting sufficient vitamins, minerals, and proteins to maintain their body and the cardiovascular function. Obesity affects the cardiovascular function, especially with patients whose BMI is greater than or equal to 30, have high risk of, myocardial infarctions. That's a heart attack. Exercise affects our cardiovascular function. It's important for us to encourage our patients, to do regular aerobic exercises. Tobacco, again, we mentioned nicotine constricts the vessels and, causes blood clots. Illicit substances and alcohol use also affect our cardiovascular function. What are some age-related changes that we see in older adults with, cardiovascular function? They have physical deconditioning. This can result in atrophy of their left ventricle. Remember, we said the left ventricle wall is very thick, right? Because it needs to be strong, because it has to pump out, that blood into your circulatory system at a good amount force to give us enough cardiac output, right? So if your muscle is deconditioned, then it's not going to pump properly. Decrease elasticity of the aorta. So if the aorta is not as elastic, if it's stiffened, then even though the blood is pumping, even if the ventricle pumps the blood out, there's a lot of resistance in the aorta that causes the cardiac output to go down. Rigidity of the valves. The valves aren't opening and closing properly, and sometimes this can cause, the blood to have backward flow, retrograde, regurgitation, we call it, right? Stenosis of the heart valves. That's when they become very stiff and they don't open enough, and the blood doesn't go from the atria to the ventricles. Then you have the stiffening of the arterial walls, right? Fibrosis of the heart chambers leading to hypertension. Formation of atherosclerotic plaques and narrowing of the arterial walls. This can lead to an increased risk of blood clot formation, causing a stroke. Right. Common cardiovascular health issues related to aging include hypertension, coronary artery disease, congestive heart failure, and atrial fibrillation, also known as AFib. These are the common ones. So how do we promote health? Remember, we talked about the levels of prevention, right? The primary, secondary, and tertiary prevention. How can we do primary prevention? We can provide education. We need to intervene before these problems start. That's where our primary prevention happens, right? Where we are, eliminate modifiable risks. For example, obesity, inactivity, tobacco use, home and occupational safety hazards, and banning substances, by the government known to be associated with causing these problems. These are ways we can, provide primary prevention. And secondary prevention includes our screenings, right? Screening to identify diseases early and, prevent them from getting worse, right? For example, the different tests we do, the, different screenings we do. All of these will help, prevent cardiovascular issues. Then we have tertiary prevention. That's when we're going to manage the disease. Post-diagnosis, the person already gets diagnosed with hypertension or heart failure. Now this is where tertiary prevention kicks in, where we can help them manage their disease, right? So it does not become worse. For example, if we don't manage hypertension, it can lead to a stroke. So this is where we provide that education. Okay, and that is done for our first lecture on the cardiovascular system. We will talk a little bit more about this in class, and if you have any questions, I will be more than happy to answer those. But please go ahead and read the chapter, assigned chapter in your Canvas that's listed there in Canvas, and the videos that I posted, because those will really help you to understand the concepts we covered. Okay, I'll see you in class.